Hello, my name is Dr. Chuck Crew, and I'm a psychologist and behavioral sleep medicine specialist based out of Houston, Texas. The evaluation of comorbid insomnia and sleep apnea can be complex and challenging. Today, I'd like to share about a case which demonstrates some of this complexity. Angela is a 63-year-old woman of normal height and build who presented to her primary care physician with concerns about her sleep that have been present for at least the past 6 weeks. According to Angela, it was taking her about 2 to 3 hours to first fall asleep, and at most she's sleeping just 3 hours, despite spending 8 hours in the bed each night. She reported near constant awareness of her surroundings during most of the time she was lying in bed. Her symptoms were fairly constant, and she was tired all during the day. In contrast, Angela's daughter reported that her mother would typically fall asleep quickly, within 30 minutes of going to bed. Her sleep time was over 6 hours, and she snored mildly during the night. Based on the initial clinical assessment, Angela's complaints fulfilled the ICD-SD2 criteria for paradoxical insomnia. This is a sleep disorder where individuals perceive that they are awake throughout the night and sleep deprived, despite their generally sleeping okay and getting a sufficient amount of sleep each night. Although many treatments for paradoxical insomnia are available, Angela was started on a sedating medication as an initial approach, specifically zolpidem. On her follow-up visit 2 weeks later, Angela denied any improvement in her sleep, nor feeling any better during the day. She was referred to a behavioral health specialist to participate in cognitive behavior therapy for insomnia. Despite good adherence to her medications and following the recommendations she received in therapy, Angela's symptoms of insomnia persisted. After another month without notable improvements, Angela's doctors consulted with sleep medicine, and a nocturnal polysomnography study was arranged to investigate other possible causes for her insomnia. The results of the sleep study were quite revealing. Angela slept for almost 6 hours, and her apnea-hypopnea index was 74.6 events per hour. She met criteria for severe obstructive sleep apnea. After educating the patient on her polysomnography results, the sleep physician explained that obstructive sleep apnea was the cause of her insomnia. He recommended that she continue cognitive behavior therapy and prescribed continuous positive airway pressure therapy. At her follow-up visit 3 months later, Angela reported sleeping soundly for 5 to 6 hours each night. Her anxiety with regard to sleep also decreased significantly, and her tiredness during the day had improved. I hope Angela's experience can help you recognize patients in your own practice. Older adults presenting with features similar to insomnia should be examined for symptoms of sleep apnea and a sleep study considered to render a definitive diagnosis.